So now we're fortunate to hear from Dr. Scott Ratson, who is a distinguished lecturer at the School of Public Health and Health Policy. And he's going to be discussing how to obtain public acceptance of and adherence to guidelines on a global scale.
Great. Good morning, good afternoon, everyone. I'm really excited and appreciate the opportunity to be here, but to really follow some great presentations, and Garrett really helped the stage, helps set the stage, as well as others here, of what the potential is with this vaccine credentialing. So I'm going to go fairly quickly. You may see there's a lot of slides here, but I'm going to try to move. What I've been asked to do is how do we attain public acceptance of and adherence to guidelines on a global scale? And it is a big challenge. We've established this CONVINCE initiative, which stands for COVID New Vaccine Information, Communication, and Engagement. And we did presage this dialogue actually last year at the UN High-Level Political Forum when we launched CONVINCE, really with the ideas that we need to have strong and best communication to diffuse a lot of the great ideas in the science that we've heard thus far today, and all of you have been working on. Just my disclosure slide, just sort of quickly, I do some other work, some of which has been supported by the Commonwealth Fund, Merck, J&J, CDC Foundation, and others. And nonetheless, today, I'm really trying to give some ideas and an overview. Hopefully that will inform the strategies going forward. But to remind, how we look at health is different if you're looking at this elephant, if you're trying to figure how many legs it has. But it really is something that we all need to do together as a society to ensure the conditions at which everyone can be healthy. And I know we've aspired to that, but we've noticed in the last decades that health challenges have certainly evolved. In 2006, it was the most important foreign policy issue of our time in The Lancet. But yet, Margaret Chan well said, the days when health officials could issue advice based on the very best medical and scientific data and expect populations to comply may be fading. And this was very prescient now when we're looking at where we are today, when our world has health communicated everywhere. But the intermediaries that we used to trust, and many of you on this Zoom meeting, were the trusted independent arbiters, or were the ones that have really developed what so-called truth and evidence is. But we had this challenge that's there from the intermediaries, and the intermediaries also, as we know, have been sponsored sometimes by states and sometimes by others via social media, where we have this hyper-collected world where misinformation can happen in a snap. And this is just from a study that Heidi Larson and others have done at the Vaccine Confidence Project, just showing how quickly on vaccination, and this is what HPV, how quickly a rumor or a fact that may seem reasonable can spread. And this very quickly also translated into policy, including HPV vaccine being taken off the market in a number of those countries. But, you know, I've been working in the field of communication, and even in today's front page New York Times, the article says is that communication we need more of, but it's not a science. But, you know, it really is, it's a social science. And I'm going to talk a little bit more about the evidence that we have in the time of COVID and what we can do with it. And this bases on a variety of areas. I chose this current bibliography on health risk communication because I know the National Academies has had a number of meetings on this, and I participated with Baruch Fischoff not too long ago, who's really one of the global experts. But we did a review years ago, but it reminds us that what we're dealing with in communicating health and risk in this matter of people making choices of vaccination is we need to have ongoing exchange of information with the public. And as we communicate about uncertainty, we even have more issues to deal with, and couple that with the fast speed of communication and the new technologies and the fact that we don't have learned intermediaries, or maybe people would even say strong systems for communicating, we have an extra challenge. We looked at this in the Journal of Health Communication. I've been editing this journal for 26 years. This is a special issue that we have on vaccine communication in a pandemic. And just to note, everything from the Annenberg School at Penn, Bob Hornick and his team, looking at Black Americans, Ruth Parker and I at Emory worked on vaccine literacy. We have a global study. The Hopkins folks have shown the rapid decline of trust. And then there's a whole global ongoing bibliography on promoting vaccine literacy. But even with all of this, we have the evidence, we knew what to do. And I serve on the board and with Julie Pavlin, who leads it, of Global Health. And we met in February 2020, when you might recall it was just a public health emergency of international concern. And Larry Agostin and I on the board said, we need to write something quickly. And we knew exactly what we needed to do. We needed a coordinated, trusted source. And we needed to do this with government, media, tech platforms, private sector. And we called for that. And we believe still today that has not happened, which I'll show in a moment. But also, this was the 5th top paper, and we've reprinted it. And I see just this week now, the IMF, WHO, World Bank, and others are coming up with a global one. Maybe we are on the right track. But even though we said this, everything we believe was fumbled. As I mentioned, Larry and I and Ken Rabin wrote about really what's happened with the science being perhaps more clear, but the message has been muddied. And this was written April 30th. And actually, since that time, we've had the mask question 3 times, policy changes by the CDC. And we asked at this time, why don't we start to discuss more on the credential or passport in the article? But it's not just what we say from a polemic, although I'll come back to some ideas at the end. We've been looking at lots of data and other ideas of how to do that. Last year, we did one of the first global surveys on a potential uptake on vaccines. We were questioning the hypothesis that Heidi Larson and others for years have been doing on vaccine confidence waning. And at that time, when a vaccine was not even approved yet, we nonetheless had a fairly good percentage of the population, shall we say, that was willing to accept a vaccine and take it. But we also wanted to see what would be the motivating sources. And we asked, are the government and business community working together to restart the economy? And we had other sub-questions, but I wanted to show this one to show that we thought there was upside potential. Really fewer than half had thought the government was working with the business community. And these were some of the questions we were trying to ascertain, where we knew a passport or credential or some recognition of certification would be necessary. So we wrote about that in PLOS1 and put a whole score sheet together. But we also just reran the survey. Last year it was 19 countries. We did it in 23 countries. And I just took one question because it's under review right now. But we asked how many people would believe that proof of vaccination should be required for international travel. And as you could see, this one was much higher, well, is higher than even some of the questions on mandates that we also have in the study. But we did show, for the most part, broad acceptance across the board in international travel. The only article I could also find on some domestic travel is Heidi Larson and her team just did something in preprint on domestic versus international in the UK. And international continues to test higher of people's willingness to get vaccinated. But just as we have found in the United Kingdom, about 74%, very similar in that preprint study. And then also in the United States, there's another preprint that was just done from the COVID States project that I found. And as you can see in the US, over the course just completed on July 7th, about 70% of the population, which is similar to what we found, also does approve of federal, state, and local governments requiring a vaccine. So people are agreeing on the mandate question, still the certification, credentialing question, and others are not totally clear yet. And what ends up happening in our world in the United States, just like we have the imprimatur of the social media, they also sometimes have the loudest voice. So facts have not been important as they ought to be. And back to the credentialing piece, the Beaumont Foundation asked people in the US what a vaccine confirmation document would be called, what they would prefer. And with this forced ranking, more people chose verification, certificate, credentialing, passport, and you see all the way down. So what we call something is going to be very important, and how we recognize it is going to be very important as well. And this also is how we call people who are not even getting vaccinated, that might have been called vaccine hesitant, might be the ones that get credentialed for being tested or otherwise. But I just want to point out that we looked at even this in the US again, across the country, 138,000 respondents. And we were just trying to say, were people vaccine hesitant, as the media was saying day in and day out? We weren't getting to 70% because they're hesitant. President Biden said he didn't believe they were hesitant. Others said we could overcome it. But we found that they really weren't hesitant. They were just ready, but the system didn't give them the access or the ability to easily get vaccinated. And when we unpacked this, we started to say, please do not call people vaccine hesitant. The avid people were the ones that were enthusiastic, but had difficulty booking appointments. Receptive, it might have been just difficult to get to an appointment. And neutral were some people that were not actively engaged. So we think if we redid this now, and we are tracking this with Frisia, which is the patient intake software group, we're probably move most of the blues over to get to the 70%, the milestone that the US just hit, but we have not, and we're not really able to get to the vaccine resistant at this juncture. So what else do we need to do with communication? It's not just these surveys, it's also we need to listen. We completed a qualitative listening project with the Commonwealth Fund. And just in short here, one, that people want to be heard, and they also do, in fact, have some impact on the healthcare system decision-making down to the local level. But more importantly, what we found is trust is the most important issue and the most important variable that we need to build. And the more we continue to erode trust in our governmental institutions, the more difficulty we have. And we've seen that even with the disparate systems, at least at this juncture, as we're trying to get back to work from the local credentialing. I say local because I live in New Jersey. It's a different system than New York. We're trying to figure out, of course, we have a tri-state area that things keep changing here, notwithstanding where we are without federal guidance. So the strategies need to have all the different players engaged. So the last couple slides, I'm going to bridge more to some of the communication strategies, but it's not just communication. And I bring that up because Neil Ferguson, who's a historian, wrote The Square and the Tower, and Anne-Marie Slaughter, who now runs the New America Foundation, formerly dean at the Woodrow Wilson School at Princeton, have both written how society has changed. The square and the tower, meaning that in the picture in Siena, that the decisions would be made in the tower and people in the town would follow. And that was kind of how we've been dealing with global health and how we've been dealing with a lot of these mechanisms. We have the state as a dominant actor, and people make decisions that are more power-based. But as Anne-Marie writes, we've moved more to this network approach. And we have to figure how to work in this world with this networked approach that doesn't allow for a top-down, but a bottom-up and really a triangulated piece amongst different groups. And just like we've known since Aristotle's days of that rhetoric, people still, and even more so now, make their decisions from their hearts, influenced by emotion, fairness, empathy, and intuition. Passion is still the mover to action, but we want to have reason as the guide. So this is just putting it together in a simple approach. Just to jump through that, when I had worked on this in my last senior fellowship at the Kennedy School, and we were trying to build this idea of strategic diplomacy. So it's not just about messaging, which is what some people think communication is. It's not just public relations, which suggests telling people what to think about, not necessarily what to think. It's not just segmenting in social marketing. It's not just policy making at the local or city or state or regional level. It could be with nudges, but even Donald Thaler this weekend said that his nudges are not enough. It is developing long-term health literacy, which is not an overnight piece. Multi-sector engagement and partnerships, as Garrett and Angie and others have spoken about. And then finally, how do we develop a social norm and sustainability? And this also is an adoption curve that takes many years, and we could match this if we had time to look at what we did with tobacco, of changing tobacco around the world with all these different areas, as well as looking at what we'll need to do with vaccination. These have gone over just that, I was mentioning the challenges. I have a couple of these. The one thing that's sort of been skipped over, I'm curious, I have my global entry card, I got my yellow card, my white card, but is there something also that will be, as the New York State is a paper-based one, but are there things in between? The Safe Travels is a voluntary which is more of a badge that should be used in the tourism industry, that if you went to a hotel, you would know that they met certain criteria. So how do we think about badges and other ways of getting people on board? Last two slides are my just ideas to think about. Can we anticipate and counter the disinformation that we'll get from the vaccine opponents on the credentials? That will happen. Again, is it going to take my liberty away from me? Is it an affront? So we need to already begin talking that this is to protect your health, to protect your liberty, to protect your freedom, to one, have both international travel, go to everything from a local restaurant to a concert to the other parts of people's lives, and how we can do that in an ongoing way where we have the chorus of multiple sources saying that. How do we have additional data? Can we start to even show, I know the systems can do this, not only on the protection and the durability and reminders, but how can we also perhaps add in that post-marketing surveillance? And frankly, we've lost some of that in the United States. We don't have good data on breakthrough infections because we're only counting those that make it to hospitals. There are a lot of other ways that we can use this technology and think about it. And it all doesn't have to be public facing. So of course, it's the private facing and other pieces that we can leverage. How do we have more strategic diplomacy strategies? How do we approach the acceptance? So as we heard, Israel's joining the EU. Where's the transatlantic dialogue? Where are these other places where OECD and others continue to have economic development and cooperation? And then finally, is there an equitable approach to have these for schools and universities, hospitals, healthcare services? I think we need to particularly move in places where it's obvious. And the last one is, what are some of these ideas? We need to advance strategic communication from local to global. I call it, we need a chorus. It's not just the right message, but the doses of the message, having that with novel, creative, social, traditional media, engaged throughout society. Again, have the dialogue. The dialogue is important for people to feel confident about the privacy, security, the data protection, the equity. Thirdly, how do we get business involved? The businesses are already moving much faster in the United States and other parts of the world, the multinationals, to mandate vaccination for employees as well as for customers, and have some confidence that they're doing the right thing in society. Can we do that together? Is there a pledge? Is there a badge like that Safe Travel badge or the Trusted Traveler program or others with health systems? And then finally, can we support and galvanize these vaccine credential organizations? It sounds like that's being done, but how can we continue to innovate, leverage data, interoperability, privacy protection in other ways, and ultimately measure the success with health and vaccine literacy? So the final thought is Helen Clark's, reminding us on this independent panel for pandemic preparedness and response. Our current institutions, public and private, fail to protect people from a devastating pandemic. Without change, these institutions will not prevent a future one. It's exciting to be, part of this and to hear what Garrett and others have been doing. I know we worked together on the Innovation Working Group on Women and Children's Health, and we're starting to presage the potential of digital health. We have the science at our hands. We have the ability at our hands. We need to figure out a way to do that with the institutions that we have, or develop new ones that can do this in our 21st century. So thank you very much. I'm going to stop my screen sharing, turn it back to you, Saskia, and hope we have an opportunity for some questions.